Good afternoon. My name is Geoff Vince, and I am chairman of the Biomedical Engineering Department here at the Cleveland Clinic. I'd like to thank the organizers for inviting me to your symposium, and I hope you'll be just as excited as I am about the research that we're doing on cardiovascular disease. So thank you again. I'd like to talk a little bit today about some of the work we're doing on ultrasound, on detecting and hopefully preventing cardiovascular disease. So why do I work on ultrasound and not MRI or CT? Because those pictures are much prettier. So you can see here on the screen on the left, we have an ultrasound image, and it really looks grainy, and it's very difficult to make anything out. And yet the MRI image at the top is of an ankle is beautiful. It's very, very high resolution. And this is a CT we have of a foot in a shoe. And you can see again, we have exquisite detail. So why work on something like ultrasound and not MRI or CT? Well, the reason I work on ultrasound is it's one of the easiest ways to address an unmet clinical need. So because I work in a hospital, we do research because I enjoy research, but I also do it because it's fun. And I also do it because it's a way of helping patients. And the best way to help patients is to find a problem and to solve that problem. And one of two of the physicians that we came in contact with, Dan Clare and Heather Gornack, came to us with a really nice problem that I thought ultrasound could solve. So what was the problem? Well, this is a slide I got from Heather Gornack, and she was talking about carotid artery disease, and the carotids are the blood vessels that are in your neck, and they supply blood to your brain. And it's one of the major causes of stroke. When people have a stroke, it's usually this vessel that is involved. So she highlights 4 areas here of particular types of disease, and I won't go into all of the details. But if you look at number 4, it's my wish for the future is moderate but high risk carotid artery lesions are identified by non-invasive testing. And what that means, sometimes patients have a blockage in the carotid artery, and it's not very big, but it could be very, very dangerous. And looking at the size of the plaque is not really indicative of what's going to happen to that patient. It might be that that plaque will grow and just cause a regular blockage. It could be that the plaque would stay the same size, or it could be that that plaque could burst and immediately cause a stroke. And right now, there is no way of determining what is going to happen to that plaque. So she also said, once we have a way of determining what happens to that plaque, we need outcome studies and clinical trials to demonstrate that these tools work better for the patients. So if we manage to find a way of determining what happens to that plaque, we need to then do a study to prove that it works. So I've done a lot of pointing at my neck, but this is actually what it looks like. So here you can see the artery. This is the common carotid artery. This is the internal carotid artery that takes blood to your brain, and the external carotid artery, which takes blood to your face. And when you do an ultrasound from the side, this is the image you get. So this is the common carotid artery. This is the internal artery. This is the external artery. Now, this is what we see in patients. Here we have a patient who has symptoms. They have headaches. They don't feel well. They have a problem with blood coming up through that vessel. It's forming blood clots on a plaque, and it's going up to their brain. And if you look at this very grainy image, it doesn't really look very different from this patient who is asymptomatic. So this patient has symptoms. This patient doesn't have symptoms, but it's very difficult to see anything different with these plaques. And the problem is that grayscale ultrasound is based on brightness. And it's good at detecting interfaces where you have a difference from air or water or blood to tissue. It can detect those interfaces. So it's very good at giving us the geometry of plaques, but it's not very good at giving us the composition of those plaques. So can we fix that? Let's look at MRI and let's look at CT. Well, MR produces beautiful images, as I've shown before, exquisite detail. But the problem is MRI is very expensive. You need a facility to put them in. You need a medical physicist. It's very difficult to get a patient to an MRI machine. You can't have any metal. And in the US, most insurance companies want you to get approval before you even go. So we're not going to use this as a screening tool. This isn't something where people could go to their hospital or their doctor's office and have a quick scan. MR is not going to work. What about CT? Well, this is a CT machine. Again, very beautiful images, very, very high resolution. But again, very expensive building, very high radiation dose, and again, very expensive. So this cannot be used as a screening tool. So how can we screen patients, screen their carotids, just to check to make sure that they don't have a dangerous type of lesion? Well, let's look at ultrasound. Ultrasound is very inexpensive, relatively. It's small. You don't need to shield from radiation. It's portable. You can carry it around. Here we have one that's the size of your hand. This can be used for screening. A more typical ultrasound machine looks like this, and they're used in hospitals and clinics to look at everything from abdomen, neurological, urological, and vascular disease. So why don't people use ultrasound to look at carotid vascular composition? Well, as I said, the image is based on changes of acoustical scattering. So when you have blood, it scatters ultrasound to a certain extent. When the blood then comes in with the tissue scatters it to a different extent. And so it's very good at finding those boundaries, but it's not very good at giving us the composition. It's often referred to as poor man's MRI. The other problem is as you go through the tissue, the signal degrades. So the resolution decreases with depth, and there's attenuation, there's artifact and diffraction. So I'm going to show a little video, show you how ultrasound works, and then I'll tell you exactly what we do. So here we're looking inside an ultrasound probe. You can see that there are piezoelectric elements on here. They put a voltage in, and the voltage produces ultrasound. The ultrasound goes out to the tissue, it comes back, and it creates a voltage. And it's that voltage that's used to make an image. Now, of that voltage information, a lot of it is just thrown away. Here we see the ultrasound going out, it hits some tissue, and it comes back. And that happens many, many times a second. And here we have some diagrams. This is just a simulation to show the images we get, and this is a phantom image. And we can scan across the whole ultrasound to show a picture, and here we have a fetus. So that's how ultrasound works. But the message I'd like to take home is that we get a voltage. What we get back from that ultrasound is a voltage. And the voltage looks like this. So we have voltage on the y-axis, and we have time, which is distance, on the y-axis. And to make an image, we typically look for all the peaks and troughs. We throw away all of this data underneath, and wherever we have areas of high voltage, we make them white on the ultrasound image. And wherever they're low voltage, we make them dark. And that's how you make an ultrasound image. But remember, we throw all of this voltage information away. So is there anything in that voltage information we can use to give us more data about what the plaque is made from? So we actually developed a technology previously where we could go in, we could look at an ultrasound image inside a coronary artery. This is called an intravascular ultrasound image. And we pick an area inside the ultrasound image. This is a coronary artery. We find the same area on a histology section of the same artery, and we teach the computer what the frequencies are here, what's the voltage here, and what kind of tissue is it here. And we can correlate those voltages, those signals, to a particular tissue type. So instead of having a grayscale image like you see here, we can actually apply color in real time, and we can give an accurate indication of the composition of the plaque. And so this was developed by my group at the Cleveland Clinic. We licensed it to a company in San Diego in 2002, and there are now over 7,000 systems worldwide. This is what the system looks like. This is me actually in Favalero Hospital in Argentina with Dr. Graf. And you can also run it from the ultrasound machine inside the catheterization lab. And then we actually OEM'd it to GE, Philips, Toshiba, and Siemens. So this technology has really taken off. But this one works inside the body with a catheter. Remember, we wanted to do the outside of the vessel, aiming at the carotid arteries. So, well, that's easy. We just take the technology that we developed for inside with the intravascular ultrasound, the IVUS, and we just make it work for the external ultrasound. Well, you can't always compare the two. And you can see here, there's a range of parameters that are very different between these two technologies. Yes, they're both ultrasound, but they work in very, very different ways that are not comparable. So what we had to do is we had to take a regular ultrasound machine and we had to tap into the electrical components of this ultrasound machine to give us access to that voltage information. And we do something called spectral analysis in the frequency domain. Anyone who wants to know more, please reach out to me or read some of the papers. But we tapped into the ultrasound, we get those data, and then we started to do a study. And what we did is we took 50 patients and we scanned those patients just before they had that artery scraped out. And we got the scrapings. We actually got the tissue that came out. And then we could correlate the voltages to the tissue type to, again, train the computer on the type of tissue that's in the patient's neck. This is called machine learning. It's a machine learning technique. And those images look like this. So here we have an ultrasound image. Again, it looks really bad. But more importantly, what we got is we got the tissue that came out at the same time. So here we have in vivo. We did ultrasound again ex vivo. We did it in a water bath. And we got the tissue. And what this allows us to do is to take the ultrasound, take a tissue section. We can look at the voltages in these regions around here. We do our statistical classification tree, our way of looking at those parameters and seeing what type of tissue they relate to, and again, allow us to predict the type of plaque that a patient has. So we now have a tool, and I'll show you some examples, where we can predict what the plaque is in someone's neck, what it's made from. Well, what does that mean? Well, once the tool is developed, we need to scan asymptomatic patients with those intermediate lesions and follow them up over time. And we need to correlate that composition with patient outcome. So if we scan a patient today, 2 years from now, they have a stroke, we can go and look and see if there was anything in the scan today which was going to indicate that they were going to have a stroke. And so we actually got $4 million from the Department of Defense. So if you remember, Dr. Gornick said that she wanted, once we developed a tool, she wants better outcome determined by clinical trials. So we have the tool. How do we know it works? Well, we wanted to see if our new composition tool correlates with future strokes. What effect does diabetes have on plaque composition? We know that people with diabetes have more strokes, they have more vascular disease. And then can we look at how that plaque progresses in asymptomatic patients? So we are currently doing a study. We're looking to do 1,500 patients over 3 years. We're doing it here at Cleveland Clinic and at the Veterans Medical Center in Cleveland. And we're scanning patients. And we're using a regular ultrasound machine. We're collecting the voltages from those ultrasound machines. And we're getting the patients to come for a yearly health check. And we're going to continue doing that until they have symptoms or they have an intervention. They may have to go in and have that plaque scraped out, or the study comes to an end. So we're going to enroll these patients for 3 years. We're going to have 1 to 3 year follow-up. And hopefully we'll be able to use this tool to say that if a patient has a particular type of plaque, then they are 2 times or 4 times or 10 times more likely to have a stroke, and they can have an intervention or a medical therapy earlier. So I'm going to wind up my presentation here. I'm getting a little short of time. I just want to thank my team, Russ Fedor, Sharonica James, Scott Andrew Eden, and Jackie Loftus, and then my vascular surgery and vascular medical colleagues. Thank you.